Piyush Bansal, we have our chairperson Dr. Rajkumar Sharma and co-chairperson Dr. Manisha Nada present over here. We'll wait for another few minutes for the rest of them to join us, otherwise we will begin. I'll just do a roll call. So we have Dr. Parvati over here, okay. Dr. Nupur Bhatnagar, Dr. Amit Kumar, Dr. Priya Suman, Dr. Nabatika Mohanty, and Dr. Mahalakshmi Mat. Anybody else apart from them? What can you tell me your name, doctor?
Dr. Shivani.
We need to start actually.
Start then. Have the first person come in, Dr. Parvati. You can sit, Dr. Shivani. We'll call you in time. Diabetic retinopathy का लगे नहीं इसका ये अच्छा ठीक है डॉक्टर शिवानी चतुर्वेदी ना ओके एक ही है where is the timer? Can somebody keep it such that हमें भी दिख जाए?
Yes, this is the third one.
ओके ठीक है बेटा बाद में कर देंगे गैस लगा दो इसमें बस लगा दो और it's loaded? Yes, you can start on that.
Okay, good afternoon. Today I will be presenting my study on ellipsoid zone loss and overlying retinal changes in type 2 macular telangiectasia based on optical coherence tomography and OCT angiography. No financial interest. Macular type 2 is a neurodegenerative vascular disorder which is bilateral and can be non-proliferative or proliferative, and presence of perifoveal retinal whitening, crystalline deposit, etc. are described in the clinical findings of MACTEL. And OCT is an invaluable tool in diagnosis with characteristic OCT findings. Recently, OCTA has helped us to study the abnormality in perifoveal capillaries in these eyes with deep and superficial capillary plexus involvement, rarefaction or loss of capillaries, abnormality of capillaries, and invasion of the outer non-vascular retina. The MACTEL study has reported EZ loss as a surrogate measure for visual function in MACTEL type 2, which might be considered more suitable than microperimetry since it is very objective, and EZ loss has been identified as a prognostic biomarker. Recently, ENFAS imaging have been described to evaluate the extent of ellipsoid zone loss in MACTEL. However, the correlation of EZ loss with other OCT and OCTA findings in non-proliferative MACTEL has not been well described. So, aim of our study was to report changes in retinal layers overlying areas of EZ loss in type 2 MACTEL based on ST-OCT and OCTA. So, it was a retrospective observational study of 1 year duration, and 40 eyes of 22 patients diagnosed with type 2 MACTEL having documented EZ loss was involved, and patients with other concomitant macular pathologies and media opacities were excluded from the study. So, OCT and OCTA scans were acquired using spectralis machine. The preset 20 micron slab of choriocapillaries is moved to the ellipsoid to generate an ENFAS image of the ellipsoid. Then the limit of EZ dark area was delineated. In cases for which a vascular signal appeared on the outer retina, image was transformed into white and black, and it's going to reinforced and superimposed on EZ ENFAS imaging. And coming to the OCT features, island drape sign, hyperreflective middle retinal layers, presence of crystals, hyporeflective inner and outer retinal cavities, outward bending or collapse of inner retinal layers, retinal pigment clumps, etc. were noted. And OCTA was graded into grade 1 to 4 based on the presence of vascular anomalies in the temporal, nasal and circumferential, and presence of neovascularization. Coming to the result, 40 eyes of 22 patients were included and mean age was 64.7. The mean visual acuity was logMAR 0.3, and among the OCT features, hyperreflective inner and outer retinal cavities were the most common findings. And on assessing the visual acuity, outward bending of inner layers, that is collapse, and hyperreflective retinal pigment clumps, presence of macular hole and others were associated with poor visual acuity. So hyporeflective cavities in inner and outer retina was the most common findings, which are usually degenerative, and visual loss was moderate in these eyes due to associated EZ loss. And hyperreflective middle retinal layer has been identified as one of the earliest findings in type 2 macular, but in our study less than half of the eyes had this finding, maybe due to more advanced presentation in our study population. Coming to the structural correlation, bending of inner retinal layers occurs due to the collapse of the layers, and hyperreflective intraretinal lesions are usually associated with pigment plaques. Both these findings were associated with poorer visual acuity. On opta examination, grade 3 and 4 were mostly seen, and opta grading, as obviously the grade 3 and 4 were having poorer visual acuity. 80% of the eyes had significant abnormality of both superficial and deep capillaries, and ellipsoid zone loss eyes had severe grades. Outer retinal vascular invasion was seen in 47% of patients, and this correlated to EZ loss areas in 84% of the eyes. So, occurrence of omnious proliferative macula with subretinal new vessels is a relatively rare event. It can be preceded on opta by a phase of invasion of the avascular zone. The DCP vessels involve outer retina specifically at the area of EZ loss. So, EZ loss and corresponding outer retinal opta could be used as a screening tool. In a study by Godric et al., 83% eyes had capillary proliferation circumscribed to area of EZ loss, which is comparable to our study. Limitation was it was a retrospective study with small sample size. So to conclude, opta and SD OCT will be useful in evaluating disease severity and also comprehending the disease severity, suspecting proliferative disease, prognosticating and planning follow-up. These are my references.
Thank you, Dr. Shivani. Would you like to call this as a macular hole as your finding, or the loss of tissue? Because in macular hole you don't find loss of retinal tissue. This is because of the retinal tissue loss.
No, this is because of the retinal tissue. It is a vascular and degenerative disease. Muller cell loss is there and vascular changes are also there.
It does appear like a macular hole, but actually it is not a macular hole.
Then can you just show me the picture once again?
Looks like a cement.
You'll have to go back, doctor.
The first
Stop
picture.
just before this. This is the one that you're talking about? Yeah, so you have a collapse of the inner retinal layers. So again, this is classical in macular type 2. So
This is not called as macular hole.
did you say macular hole?
No.
Okay.
Other findings, among the other findings, there are pseudomacular hole and all.
Okay.
This one is not
Light,
macular.
light.
What could have been the findings if it was a foveal burn? To me, the third picture it looks like maybe it's a foveal burn. Is it?
No. There is outer retinal cavitations are there in the third picture with the collapse of layers.
Right, doctor. Thank you very much. We have Dr. Priya Suman. Come.
Good afternoon, everyone. I'm presenting on association between hypertension and triglyceride glucose index in BRBO. There is no financial disclosure. Retinal vein occlusion leads to notable vision loss and rank as the second most common vascular ailment affecting the retina in more than 60 million people globally. It can be classified in two subtypes depending on the site of the obstructed blood vessel, BRBO and CRBO. BRBO with an annual incidence of 2.14 by 1000 in the population over 40 years of age exhibits a higher prevalence compared to CRBO. Population-based studies report a prevalence rate of 0.5 to 2% for BRVO and 0.1 to 0.2% for CRVO. The risk factors associated with BRVO are advancing age, hypertension, diabetes mellitus, dyslipidemia, cardiovascular disease, hypercoagulability, oral contraceptives, pregnancy, and ocular factors such as intraocular hypertension or glaucoma. Patients with long-standing arterial hypertension undergo retinal artery atherosclerosis characterized by intimal layer thickening, medial layer hyperplasia, and arterial wall hyaline degeneration. There is compression of vein at the AV crossing, leading to abnormal hematological factor and degenerative changes in the vessel wall. The consequences of venous occlusion are intraretinal hemorrhages, macular edema, and ischemia. My study was a hospital-based case control observational study which included patients with 67 patients with newly diagnosed acute stage of BRVO, and they were compared with 70 healthy control groups matched for age and gender. The mean age was 61.2 plus minus 8.4 years in group 1 and 60.4 plus minus 10.1 in group 2. My exclusion criteria were serious cardiovascular disease, COPD, anemia, history of uveitis, scleritis or retinal diseases, and coagulopathies. In recent years, it has been reported that triglyceride glucose index calculated as a log of fasting triglyceride into fasting glucose divided by 2 is a simple and reliable marker for the determination of insulin resistance and atherosclerosis. It has been shown that high triglyceride glucose index is associated with high arterial stiffness, and the triglyceride index has a clinical significance in the evaluation of microvascular damage. Triglyceride glucose index can be a new useful indicator in development of BRVO. Detailed diabetic and hypertensive status of the patients were included in my study, family history, personal history, and detailed ophthalmic examination using breast corrected visual acuity by refraction slit lamp examination. Detailed fundus evaluation were done, and blood investigations were done in the study of fasting blood sugar, HbA1c, and serum lipid profile. The statistical analysis was conducted using SPS version 2022. This is the OCT picture showing BRVO. In BRVO group, maximum patient belong to the age group of 60 to 64 years, followed by 55 to 59 years, and the control group, maximum people were in the age group of 60 to 64 years. In BRVO group, there were 36 males and 31 females, and in control group, there were 38 males and 32 females. In the BRVO, the maximum patient having systolic blood pressure in the range of 130 to 140 mmHg. And in control group, they were having maximum people were having pressure between 110 to 120 mmHg, and diastolic blood pressure in the BRV group maximum were having 80 to 85 mmHg, and control group they were having 75 to 80 mmHg, and in BRV group most of the patients are having fasting blood sugar level up to 100, and in control group also maximum having with 100. HbA1c in BRV group they were up to 6.4%, and control group 64 patients. In BRV group maximum were having triglyceride in the range of 150 to 199, and in control group they were less than 150. So thus my result was that the group showed no significant difference in average age and gender distribution. The BRVO showed significant difference in terms of hypertension compared to control group, and BRVO exhibited higher triglyceride level compared to control group, and triglyceride index was significantly higher in BRVO when compared to control group. So according to Paul R.A. conducted study RVO, the study showed the risk factor for RVO attributed to hypertension was 47.9% and diabetes was 4.9%, hyperlipidemia was 20%. So various biomarkers have been investigated in predicting the atherosclerosis, and the clinical use has been evaluated. Triglyceride glucose index is a valuable marker. Another predisposing factor as well as known atherosclerosis and hypertension. In B1MI study, hypertension was associated with prevalence of BRVO. In recent years, numerous extensive prospective cohort studies have confirmed the strong association between triglyceride glucose index and hypertension, and a meta-analysis determined that triglyceride glucose index is a useful predictor for risk of developing hypertension among general adult population. Hypertension is a significant risk factor in BRVO, substantially contributes to atherosclerosis development, and triglyceride index may serve as a tool to identify vessel wall degeneration and AV compression caused by hypertension. These are my differences. Thank you.
Very nice presentation, doctor. But so do tell me, how do you think this is going to be useful in our day-to-day practice?
So because BRVO, the risk factors is triglyceride and diabetes. So if we calculate the index will tell about the microvascular damage.
So patients, when they report to us, we've already had a branch retinal vein occlusion. So it cannot be used as a screening tool per se. It does give us information, like you said, that my patients with DRBO had high levels of triglyceride glucose. But the relevance in practice is somewhat. Another advice to you is that your study is very good, but your slides are too crowded. You should keep them minimum, and you should elaborate more on whatever you've written rather than putting paragraphs in writing.
More cases should have been shown pictorially. It was only one picture.
Does it anyway affect patient going into systemic hypertension as Dr. Piyush asked? How is it going to help the patient? Just that you are adding one more test. Any patient with BRVO comes, we say get your blood pressure checked, sugar, lipids profile. So we will add one more test to that. That's all. Or do you think there is any other importance of this biomarker? Thank you.
Did you study the nocturnal hypertension also as well? No.
Okay, thank you.
So, Dr. Radhika Agarwal, are you here?
Good afternoon, respected seniors. Myself, Dr. Radhika Agarwal, will be presenting the free paper Evaluation of Stress Level and OCT-based Resolution Pattern in Acute Central Serous Chororetinopathy, a Novel Approach. I would like to acknowledge the chief author, Dr. Riya Sharma, who conducted this study. So what we know about acute CSCR? We know that it is a posterior segment disease associated with serous detachment of the neurosensory retina, causing metamorphosia and central scotoma. It is more often seen in middle-aged men, and it is associated with emotional stress, sleep disturbances and exogenous steroid use. So coming to our study objectives, our first objective was to find a relationship between the stress levels and the clinical outcomes in acute CSCR. Second was to find if there is any association between stress levels and the OCT-based resolution patterns. And third was to recognize patients with elevated stress levels who may benefit from psychiatric intervention or counseling. So coming to the methodology. So this was a hospital-based prospective cohort study of 27 consecutive acute CSCR patients who was diagnosed with acute CSCR without any concurrent identifiable risk factor. So along with a detailed history and clinical examination, we performed EDI OCT at the baseline as well as for the follow-up for 6 months. So the stress levels were assessed using the validated standard stress scale objectively at the baseline. This is the standard stress scale 11 battery item, which consists of this set of questions. It has a possible range from 0 to 1, 1 indicating maximum and 0 indicating minimum level of stress. So coming to the outcome measures of our study, these included subfoveal choroidal thickness, subretinal fluid, PED's association with the AAA score, RP regularity and ISOS junction disruption association with AAA score. Coming to the results. So through our study, we found that the mean age of the study participants was around 40 years with a higher incidence in men, and most of them belong to urban areas. The mean AAA score was found to be 0.4, indicating a moderate level of stress in the study population. The stress score ranged from 0.2 to 0.7, highlighting the variability in the stress levels among the CSCR patients. Coming to the anatomical outcomes in CSCR, we found that the subfoveal choroidal thickness decreased from around 400 microns at the baseline to around 300 microns at 6 months follow-up in the affected eye. The subretinal fluid also resolved completely in all our patients after 6 months follow-up. Third, this was also reflected in the improvement in the best corrected visual acuity in the affected eye. We also found that patients with a higher level of stress, about mean of 0.5, were more likely to have persistent PEDs at 6 months compared to those with a lower stress level, and this was statistically significant. So this is the graph which is summarizing all the OCT features which were higher, and we found that there was a higher association with a higher level of AAA score. A statistical correlation of the study variables was done, and we found that the PED's association with AAA score was statistically significant. the subfoveal choroidal thickness and the SRF gradually reduced over the period of the 6 months, which reflected in the increase in the best corrected visual acuity. So the carry-home message is there are no previous studies to the best of our knowledge which correlated the stress levels and the OCT-based resolution pattern. So stress level is a useful prognostic indicator for the development but also the resolution of acute CSCR. So the patients with higher stress levels at baseline should be followed up for the persistence of OCT parameters and the improvement in the best corrected visual acuity. And we need to identify and provide appropriate psychiatric intervention and counseling for better visual outcomes of these patients. Thank you.
So, nice paper, but did you take care of any secondary this thing in CSR? I mean, were these patients were followed up for 6 months?
Yes, sir.
So, were there any treatment protocols or parameters instituted for these, or they were taken as that we are not going to treat them?
No, sir. After 3 months, we found that in 4 of our patients, the subretinal fluid persisted after 3 months. So we started them on oral epiledron therapy also. And the patients where we found that the PEDs persisted even after 6 months, they were referred to psychiatry as they were associated with the higher SSS score.
Was any OPTA done for patients with PEDs?
No, sir. OPTA is not available, so that was not done.
I'm surprised to see the average age of your group as 40. Don't you think this is a bit higher in CSR group?
Sir,
If at all it was there, what do you think is the reason?
Sir, most of the, according to the previous studies also, the average age was also 41 years. And
That's why you kept it at 40.
no, sir, we found it 40. And most of the study participants, they were from urban areas only. So it was like the middle-aged adults, the working population, because of their stressful lifestyle, maybe that was related with 40 years of age.
What we generally say is they are young adults, working class. You say they are middle.
What are the bias in your study? Did you rule out any contributing factors towards CSCR?
Yes, sir. We did serum cortisol levels. We did in all the patients. We did blood pressure and RPS profile. Also, we ruled out all the other systemic autoimmune diseases, any ocular disease, any previous ocular surgery history. So we ruled out every other thing which could also cause CSCR other than stress.
Any female histories? Any particular history you have in female patients?
Ma'am, pregnancy, we asked pregnancy is also associated with CSCR. So we asked for that.
Pre-pregnant? Anything?
Yes, sir.
Pre-pregnancy, anything the patient was taking? Did you ask or not? You should ask. Regarding what? What are separates?
Oral contraceptive.
So this is the general norm that you follow, that you would not intervene in a CSR for 3 months, or it was just for this design?
Sir, we followed the protocol as we treat the patients. So usually in acute CSCR, we observe the patients for at least 3 months, and if we find features of chronic CSCR like hyperreflective dots, interretinal cyst, then only we treat the patient. So the patients who showed that there was eyes-wide junction disruption, PEDs were persisting, and the SRF was also persisting in 4 patients in our study. So then we treated them, otherwise we didn't.
How did you counsel the patients?
Ma'am, we actually referred them to psychology actually.
Right, that's right. Nice.
Not anything at your level.
Ma'am, we counsel them about the disease, how it progresses, and usually it resolves. So we told them the nature and the course of the disease and the importance of stress management and relaxation therapies which they can include in their life.
You can ask for yoga, exercises and
meditation.
some
Very-
like that, breathing exercise and all.
Very good, Dr. Agrawal. Dr. Drakan said that you didn't do OPTA, but in case if you have access to an angiography for patients with persistent fluid, it's a good idea to do angiography rather than giving them the notion that it will resolve by itself. Not all cases of CSC are resolved by themselves. The longer the fluid stays there, the more photoreceptor damage can be expected in later stages. But very good. Okay, thank you. We have next Dr. Nabatika Mohanty.
Very good afternoon. I'll be presenting a case series of febrile retinitis associated with macular edema from Western Odisha. These are my acknowledgements. So post-fever retinitis can occur after viral or bacterial infections like dengue, typhoid, chikungunya and rickettsia. It presents usually after 2 to 4 weeks of the onset of fever. Presents with mild vitritis, multifocal retinitis, retinal hemorrhages, macular edema and disc edema. Pathogenesis, although not clear, could be either parainfectious or immune-mediated mechanism or a mixture of both. Although no standard treatment has been described for this entity, we can use oral antibiotics and oral steroids. So we enrolled all the patients presenting with retinitis and macular edema with a recent history of fever between January 2021 to December 2022. A comprehensive ophthalmological workup was done, including fundus photo and OCT macula. Serology reports from previous health checkup were obtained. And we did all the routine investigations like CBC, ESR, ELISA, MANTU, chest X-ray, along with some special investigations like dengue, well Felix for rickettsia, viral chikungunya, and MPICT. Macular edema was defined as the presence of either subretinal or intraretinal fluid or central foveal thickness of more than 300 microns. A resolution was defined as a complete absence of subretinal and intraretinal fluid and foveal thickness of less than 300 microns. We excluded patients with fever, with sepsis, media haziness like mild vitritis or cataract and other systemic illnesses like diabetes. And all the patients were given oral doxycycline of 100 mg BD for 7 days along with oral steroid at 1 mg per kg body weight along with topical steroids in a tapering manner. They were followed up after 1 month and then 3 monthly up to 12 months. So coming to the results, we had a total number of 18 patients and 27 number of eyes, and our mean age of presentation we found that it was 32 years with a male preponderance. Out of 18 patients, 11 had serologically positive with the highest number showing typhoid positivity followed by dengue, malaria and rickettsia. We also found that there was a seasonal variation with most of them presenting between September to March with a peak in February. Coming to further results, we saw that the eye involvement was invariable. Duration of vision loss was around 9 to 10 days. History of onset of fever was around 4 to 5 weeks. And OCT showed subretinal fluid, intraretinal fluid and hard exudate in almost all the cases. Outer retinal layers atrophy was found in one case. Macular star during presentation was present in 51.9% of the cases. However, 85% of the cases showed macular star developing during follow-up. So coming further, we saw that the OCT showed a resolution of macular edema starting from 803 to 186 by the end of 5th follow-up, and the corresponding visual acuity also improved. And this shows a linear relationship between OCT and the logMAR vision at each visit. Coming to the cases, this is one of the cases who had retinitis along the superior arcade and the small retinitis patch along the inferior arcade with macular edema and neurosensory detachment. Corresponding FFA showed disc leakage and vascular trunk leakage along with some block fluorescence due to the hemorrhages and CNP areas. So this is another case who had bilateral involvement and there was development of this macular star during follow-up. So we saw that there were different anatomical subtypes as well. They may occur along the arcades or may involve the posterior pole, maybe peripapillary or a mixed variety. Recurrences, yes, there was recurrence in one of the cases. Along the inferior arcade, the retinitis patch has increased during the course of follow-up. However, macular edema recurrence was not there. Our limitation was that we could not use a wide-angle fundus camera, so we could not document any lesions outside the arcades. A large number would have been helpful. So, in conclusion, macular edema is a common association of febrile retinitis, and visual improvement resolution of retinitis and macular edema can be achieved with oral doxycycline and steroid tablets. Macular star pattern is a common finding and different subtypes need to be studied in order for prognostication. Thank you.
you. Nice presentation. Did you have some control groups also? You said with the doxycycline and steroids. So when did you give doxycycline in all the patients
Yes, sir, we did.
and steroids also in all
Yes,
the
sir.
patients?
Yes, sir.
So this was empirically given actually.
Empirically given, yes.
Did you look at the compare the control group?
No, sir, no, sadly we don't have
That
a
would have been better
Yes.
so that you can say whether anything needs to be done or not.
Yes, sir.
Or this is self-resolving.
Yes, it is considered to be self-resolving, but since we come
Then
from
we
Western,
don't need to give
yes, sir.
doxycycline steroids specially.
If macular edema is not there is no macular involvement, then probably we can just observe. But if there is macular involvement, then we can start epical therapy.
But in your study, you have given doxycycline
Yes, sir.
steroids
Because
to
all
each
of
and
them-
every patient.
Yes, sir. Yes, sir.
Macular edema or no macular edema, retinitis needs to be treated. Okay.
Thank you.
So we have Dr. Mahalakshmi Ma.
Good afternoon, sir. Myself, Dr. Mahalakshmi Mat. I am presenting a prospective cross-sectional study of ocular manifestations seen in patients with iron deficiency anemia. Coming to introduction, anemia is the most common hematological disorder presenting with a variety of ocular manifestations. As we know, iron deficiency is the most common nutritional deficiency in India. So, iron deficiency anemia is the most common anemia in India. Almost 30% of the world's population suffer from iron deficiency anemia, out of which more than 80 to 90% of the patients are seen in developing countries. Iron deficiency is defined when the level of hemoglobin is less than 13 gram per deciliter in male and less than 12 gram per deciliter in females. The aim of my study was to determine the prevalence of various ocular manifestations which were seen in patients with iron deficiency anemia. Materials and methods. This study was done on 85 patients. Informed consent was taken from all the patients and all the patients were subjected to routine hematological investigations. All the patients which were included in the study underwent a detailed ocular history, visual acuity, slit lamp examination for anterior segment manifestation and a dilated fundoscopic examination for posterior segment manifestations of anemia. Based on the level of hemoglobin, they were graded into 3 grades: mild, moderate and severe grades. Mild grade was considered when hemoglobin was 10 to 11 gram per deciliter, moderate when it was 7 to 10 gram per deciliter, and severe type of anemia when hemoglobin was less than 7 gram per deciliter. Inclusion criteria: all the males whose hemoglobin was less than 13 gram per deciliters and females with hemoglobin less than 12 gram per deciliter were included in the study, and patients with history of hypertension, diabetes mellitus, history of any ocular trauma or any systemic illness which might lead to posterior segment involvement were excluded from the study. Coming to result wise, gender wise distribution of the patients, in my study the majority of the patients were females, accounting for 82.3% and 17.6% of the patients were males. Distribution based on the severity of the anemia, 66.6% of the patients were having mild grade of iron deficiency anemia, that is 57 patients were seen having mild iron deficiency out of 85 patients. And anterior segment manifestations include lid edema, conjunctival pallor and subconjunctival hemorrhage. None of my patients had lid edema and subconjunctival hemorrhage, and the most common manifestation was seen was conjunctival pallor, that is 77% of the patients. Next, coming to posterior segment manifestations of anemia, which ranged from variety of conditions like retinal hemorrhages, posterior pore pallor, arteriolar attenuation, cotton wool spots, hard exudates, rod spots, papil edema and central retinal vein occlusion. The most common posterior segment manifestation in my study was retinal hemorrhages, which were seen in 18% of the patients, and second most common posterior segment manifestation was posterior pole pallor, which was seen in 11% of the patient, and rarely one patient had presented with central retinal vein occlusion. Discussion part. As we see, most common ocular manifestation, anterior segment manifestation was conjunctival pallor, which occurs due to constriction of small blood vessels in the conjunctiva. Similar studies were done by Pragati Garg et al. And Jitendra Kumar et al. They also showed that conjunctival pallor was seen in 100%, almost all of the patients, that is 100% of the patient and 83.3% of the patients, and retinal hemorrhages which occurs due to hypoxia. There is substrate for retinal metabolism is reduced, so it will lead to increased permeability, reduced oxygenation and extravasation of the blood and blood products, due to which retinal hemorrhages are seen. Similar study was done by Sonal Mittal et al. They showed that the retinal hemorrhages were seen in 35.533% of the patients, whereas in my study it was seen only in 18% of the patients. Next, coming to conclusion, ocular abnormalities increases with the increasing the severity of the anemia. So all the patients with moderate to severe grade of anemia should undergo a routine complete ophthalmic evaluation. So therefore, fundus examination should be a part of essential routine examination in all cases of suspected as well as confirmed anemias.
This is a nice presentation. So what do you think that can we use AI in such cases, in anemia cases? Can we do some screening somewhere and get these patients screened out and be diagnosed? Can we do it?
Yes, ma'am.
Is there any study on that?
Similar studies were done by many studies are there, ma'am. Like they have screened a lot of patients where they have.
What places you can screen such cases? You have 70% females. So where would you like to screen them?
From rural tertiary care centers, rural places like.
Gynae-OPT.
Yeah. So I have a question that 18% had retinal hemorrhages, and that seems to be one of the most concluding part. But what you have not told us is that out of these 18%, how many were in mild, moderate and severe anemia? Because if there was retinal hemorrhages in a patient with mild anemia in the mild category, then that means there is something else there.
Yes, sir.
Right? And even the other one, I mean, you had CRVO and rod spots also over there. So again, you ideally basically need to categorize them, because conjunctival pallor is again a very subjective test. It's not something which is there. But yes, any positive finding. And also, what is posterior pole pallor?
The pinkish hue of the retina is pallor compared to normal.
No, but what that means that they're getting they're
Is it
getting.
generalized or is it posterior pole?
Where do you get posterior pole pallor?
Vein occlusions, artery occlusions.
Yeah, artery occlusion, basically CRA. So basically, you need to categorize them first as to whatever positive findings you get, whether you gotten them in severe cases or whether they're actually, blood-related retinopathies or not. That is one important thing.
Other hypoxic states also.
Yeah. Yeah.
It should be quantifiable.
Yeah, it should be quantifiable to a certain extent.
Just like saying pallor of the posterior pole, I don't think signifies anything.
Yeah.
You can say this is pallor of the posterior pole, I would say this is no.
But there is no, and this pallor has a grading. I don't think that pallor of posterior pole has any grading.
Never been described also.
Yeah.
We have not.
Yeah.
Anyways, thank you.
Good. Your presentation is very good, but there is scope for improvement. Okay. We'll have Dr. Amit Kumar there.
So I'll be presenting on the topic the role of insulin-like growth factor 1 and postnatal growth failure in ROP in babies weighing less than 1500 grams. So VEGF production and systemic IGF levels also play important role. Now what happens in preterm birth is there is a rapid fall in the serum IGF-1 levels because the maternal sources are lost. So IGF-1 levels then slowly rise after preterm birth. So greater the duration of low IGF-1, greater the retinal hypoxia and elevation of IGF levels, and more severe the ROP. So there are studies in Western cohorts showing low postnatal serum IGF-1 levels are associated with ROP. Also slow postnatal weight gain, surrogate measure for serum IGF-1 also leads to severe ROP. However, there are limited research on the Indian cohort of preterm infants concerning these factors. So considering this background, we have undertaken this study to estimate the incidence and determine the perinatal risk factors of ROP and determine the role of IGF-1 and postnatal growth failure in predicting ROP development. Our sample size estimated was 329. It was a prospective cohort observational study, and the inclusion criteria was birth weight less than 1500 grams and preterm babies less than 4 weeks of gestation. Weekly serial birth weight was estimated and monitored using growth charts as shown here on the right side, and growth failure was defined based on a Z score. So fall in weight Z score at 36 to 40 weeks of post-menstrual age of more than 0.8 compared to the weight Z score at birth was defined as growth failure. As you can see the rightmost chart, the graphs, you can see a front-end chart, the growth failure is diagnosed based on the values in the chart. So blood sample collection for IGF-1 was done between 30 to 33 weeks, and ELISA was done to estimate the IGF-1 levels. So each baby was categorized based on ROP, highest stage of ROP in either eye, as no ROP or ROP. ROP was again divided mild ROP, which required follow-up every 2 to 3 weeks, moderate and severe ROP. Moderate ROP required follow-up every 1 to 2 weeks, that is type 2 ROP based on 80 ROP, and severe ROP was the one which required treatment, that is type 1 ROP. So we had incidence of 49.5% ROP in our group, and ROP stages there are 163 babies, stage 1 in 71, stage 2 in 82, stage 3 in 9, and aggressive ROP in 1 baby. So on univariate analysis, association with ROP development was seen with the conventional risk factors which we always study: gestational age, birth weight, respiratory distress, low of the score. So the new risk factors which we wanted to study are the low weight gain per week, postnatal growth failure, and IGF-1 levels. They also showed significant association with univariate analysis. So this was a non-normal distribution for gestational age among the babies. We could see across two groups, median gestational age was more in the no ROP group compared to the ROP group. When I divided into 3 groups based on severity, again we could see it was significant difference across the groups. Birth weight also had a non-normal distribution, and median birth weight was higher in the no ROP group compared to the ROP present group. And across the 3 groups also it was statistically significant difference. Weekly weight gain was also showing non-normal distribution, and you could see across the 3 groups it was no ROP group, it was high compared to the moderate and mild ROP groups. And media of IGF-1 levels also was higher in the no ROP group, 28 compared to 18 in the ROP present group. And across the 3 groups also you could see no ROP group, it was highest 28.81 nanogram per ml, and compared to moderate to severe ROP group which was 20. Again, postnatal growth failure was seen more commonly in the group with ROP present compared to the no ROP group. So multivariate logistic regression we did, and you could see postnatal growth failure and IGF-1 maintain the statistical significance with ROP development. We developed ROC curves to get a sensitivity cutoff for IGF-1 levels. We could find 25.56 nanogram per ml was the cutoff for ROP, and weight gain per week 107.2 grams per week was the cutoff for weight gain per week for ROP. A relation between postnatal growth failure and IGF-1 wanted to see in a study, got a negative correlation. Higher the IGF-1 levels, the postnatal growth failure was not present, so it is a negative correlation. So these are similar studies done on previous studies on IGF-1 levels, and you could see our current study, we have done almost 200 babies, one of the highest sample size, and the results are almost similar, but this is the only study done in Indian cohort of babies. And also weight gain per week, we could show similar results of 100 cutoff levels across the studies. So one limitation of the study was our group included babies less than 34 weeks. So 34 to 36 weeks, then in those babies actually the oxygen plays a more definite role than the IGF-1 level. So our results cannot be generalized in those larger size babies. So to conclude, lower IGF-1 levels, poor postnatal weight gain and postnatal growth failure can act as predictors for ROP onset and severity. And we got a cutoff of 25.56 nanogram per ml for IGF-1 levels and 107.2 grams per week for weight gain per week. So future studies we can use IGF-1 levels, postnatal growth failure or weight gain per week based ROP risk prediction models for predicting ROP severity, and close follow-up of those babies who are high risk of developing ROP rather than following up all babies, premature babies. Thank you.
Excellent cohort. I just wanted to know that what is your take-home message from this now?
Take-home message is actually we should also look for the postnatal growth failure, and because these are not the conventional risk factor which we study. Usually the low weight gain at birth only we stop it. So we should follow up the growth of also these babies. And in this study we also want to see that the IGF-1 levels, whether they correlate with the postnatal growth rate or not. So we have seen a negative correlation, higher the IGF-1 levels, lower the post and the vice versa. So if future, actually the ROP screening is a big burden compared to the number of retina screening retinal surgeons present. So if we can identify those babies based on this postnatal growth failure, some ROP risk prediction models we can make, we can just closely follow up those babies rather than following up all the babies, and we can space off the, now monthly we follow up those babies who don't have ROP. If we have the prediction model, we can maybe space off this screening further and only concentrate on babies who have the high risk based on this.
And do you think that with such a high incidence of ROP that you have over here, was there any other factor that you could elucidate for this very high factor?
We had a high incidence because we have only selected babies who are less than 1500 grams. Because if we take up to 2000 grams, which is the Indian convention, we cannot get enough number of babies in the severe group. So just to compare across the groups, we have cut
No,
down.
my question is that why have such a high incidence? Those were not screened, na? They had ROP.
They were screened, all of them are screened.
No, but they were ROP, they had ROP.
There are some stage of
So
ROP.
why such a high incidence of ROP with you?
Because we got the incidence of the cutoff was less than 1500 grams in our study. So in those group we had a higher.
So any other common factor you had in these babies to have such a high incidence of ROP? I am talking about the pre. I mean, was there any other factor?
No other factor. Only the birth weight we
Only
took
birth
a lower cutoff. So it was intentionally taken so that we get more
That
babies.
I understood. But did you find any other
No other
incidents?
risk factors.
Because there are various studies on ROP which do suggest that there are certain pockets or there are certain, treatment protocols which have led to higher ROP incidence. So this again, IGF-1 levels is also one part of it. No?
Yes.
This is post. And then there are others which are pre. So what I wanted to ask you was that now that you have such a big cohort in comparison to the other studies, did you try and find something which was pre also to improve or decrease the incidence of ROP basically?
Actually, if you see, this was only, any stage ROP was 50. The treatable ROP we had only 79 out of the 300. So just in that case, thank you.
Thank you.
Can we have Dr. Nupur Bhatnagar?
I will be presenting a paper on the central macular thickness changes after small incision cataract surgery using OCT. Changes in the macular thickness is one of the late complications that may lead to visual deterioration after any intraocular surgery if precautions are not taken adequately to avoid, diagnose or treat it. Cataract surgeries are the most common performed surgeries in the field of ophthalmology, especially SICS and phacoemulsification surgeries. Pseudophakic cystoid macular edema or Irvin-Grass syndrome is a complication of cataract removal and intraocular lens implantation. It occurs as the prostaglandin release due to the surgical trauma or any manipulation leads to the breakdown of junctional complexes in the parafoveal region, allowing leakage of fluid and edema. The fluid starts accumulating in the intracellular spaces, leading to formation of cysts. Thus, the cystoid spaces are formed in the macula. It occurs between the second to fourth post-op week with the presenting symptom of slow onset of diminution of vision, metamorphopsia, photophobia, reduced contrast sensitivity, central scotoma, or the combination of any of this. It is often self-limiting and has spontaneous resolution, but occasionally can become chronic or permanent, leading to a marked impairment of central vision. High-resolution cross-sectional images of the retina is useful for identifying, monitoring, and qualitatively assessing macular thickness. OCT is a medical diagnostic imaging technology from which cross-sectional images of the retina are obtained at the resolution of 10 microns. Thus, the changes in macular thickness can be assessed by OCT. So, the aim of our study was to study the incidence of cystoid macular edema in uneventful cases of SICS. The objective was to determine the changes in the macular thickness following uneventful cataract surgery and to elucidate the optical tomographic features of macular thickness after uneventful cataract surgery. It was a pilot study conducted on patient attending the OPD department of Santosh Hospital with a sample size of 25 patients. We included patients with clinical diagnosis of cataract willing to undergo surgeries, any surgery that allowed OCT to measure the central macular thickness, and the surgery had to be uneventful with posterior intraocular lens implantation. We excluded patients with complicated or traumatic cataract, retinal or posterior segment pathologies diagnosed in the pre-op period, diabetic or hypertensive retinopathy, glaucoma, complications during the surgery, any previous history of IOL in the same eye, patient with any other topical systemic steroid use, and uncooperative and unreliable patients. In the pre-op period, we took an informed consent, BCVA, intraocular pressure by application tonometer, patency of nasal lacrimal duct by syringing, a complete slit lamp examination of the anterior segment and the posterior segment using 90 diopters lens was done. General examination of patient was done. OCT done for pre-op macular thickness as well. The patients were given antibiotic eye drops, moxifloxacin 5%, 1 drop 4 times a day, and eye drop flurbiprofen 1 drop 4 times a day in the pre-op period for 3 days. In the peri-op, tropicamide plus phenylephrine combination was used to dilate the patient's eye. Peribulbar block with 0.5% bupivacaine and 2% lignocaine solution was given. SICS surgery was performed with PCIOL implantation. The duration of surgery was noted, and it was noted that there should be absence of any complication. In the post-op period, attenuation of the BCVA, slit lamp examination of the anterior segment and the fundus using 90D lens was done, and OCT was taken in the immediate post-op period, the first, second, fourth week and 3 months after the surgery. What we observed in the 25 patients that we took, that there was subclinical macular edema at the first, second and fourth week. The statistical difference between the mean values was significant. The post hoc testing was done and the differences were seen. We saw that subclinical macular edema was noted at the first, second and fourth week review in the patient who underwent cataract surgery. The peak subclinical macular edema was noted in the first week, and at the third month review, the macular edema had reduced in our patients. Cystoid macular edema was not noted in any of our patients. OCT showed macular edema without altering the architecture of the macula. Thank you so much.
Can you go back to the picture that you had shown? I missed that.
Go back.
You shown some pictures, no? No pictures?
Sir, actually we do not note any cystoid macular edema in our patients.
What was you said subclinical macular edema, but how much did you quantify? How much of macular edema?
Sir, we noted the baseline macular thickness.
Yes, so
and after.
So comparison?
Yes, sir. In this table, we have compared for the patients the baseline.
Yes, so what was the baseline thickness?
So baseline thickness was 170 plus minus 20.
Okay. And how much was it post-op?
So post-op in most of the patients, we have documented in the various post-op period. So there has been mean increase maximum in the first week post-op period of about 30 microns plus minus 30, and which has usually most of them had resolved after 3 months.
What was the kind of macular edema over here?
So no, only no, it was not clinically suspected. There was no macular edema, only subclinical.
That I understand, but it has a particular morphology. Post-cataract surgery, if there is macular edema, it has a morphology that is different to, say for example, after a vein occlusion, or say different from a diabetic macular edema.
Yes, so there are cystic spaces usually in the outer plexiform layer seen after.
That is theoretical. What did you see?
So we did not observe anything in our patients.
Okay.
You know how to quantify those cysts? Why did you do syringing in the cases of SSCS?
Ma'am, that is a protocol that we follow at our hospital.
In all cases you do syringing?
Yes, ma'am. We do it in all the cases.
And how many days prior to surgery?
Ma'am, 1 week.
It's actually a slightly outdated procedure to do syringing. Just a Rho plus is enough in even rural setting.
If there is history of any discharge or something, swelling is there, then we do it. It's long time back that we left all these.
Good afternoon everyone. The title of my paper is Spot Urine Albumin is a Biomarker from Proliferative Diabetic Retinopathy. Raised spot urine albumin is an indicator of potential kidney damage in diabetic retinopathy. Spot urine test is a very simple, physician-friendly and easily available and reliable also. Spectral domain optical coherence tomography is an accurate diagnostic instrument for defining the in vivo histology of the retina. Optical coherence tomography is an extension of OCT, offers an imaging of the retinal vasculature. The aim of the study was to evaluate spot urine albumin levels as a biomarker for proliferative diabetic retinopathy. Correlations of the stages of diabetic retinopathy with various OCT parameters depicting neurovascular unit were also studied. It was a tertiary care center-based cross-sectional study, and a total of 104 sample size was taken. Total 78 cases and controls. They were divided into no diabetic retinopathy, non-proliferative diabetic retinopathy, and proliferative diabetic retinopathy groups. Spot urine albumin was measured using a urine test kit. SDOCT parameters like the foveal avascular zone, superficial vessel density, deep vessel density, OCT retinal nerve fiber layer, and ganglion cell analysis was measured. As we can see in this, that the association of spot urine albumin with the various stages and the increasing pathology of the disease can be seen. With the increasing pathology of the disease, we can see that the spot urine albumin is increasing. In this, we can see the association of OCT angiography parameters in diabetic retinopathy. With increasing pathology, the foveal avascular zone is increasing and the superficial and deep vessel density is decreasing. In this, we can see that the OCT RNFL and ganglion cell layer thickness is decreasing with the severity of the disease. ROC curve analysis was done, and for spot urine albumin from NPDR to PDR group, it was 1, which shows that it is an excellent biomarker for the proliferative diabetic retinopathy. So to conclude, spot urine albumin is a novel biomarker for proliferative diabetic retinopathy. It also predicts the progression from NPDR to PDR stages, and it correlates significantly with the superficial vessel density, deep vessel density, foveal avascular zone, retinal nerve fiber layer, and ganglion cell analysis on the OCT. Thank you.
Very good study. Dr. Shivani, it's important. It's very nice that you've done an analysis of different stages of diabetic retinopathy. But what I feel is it's also important to perhaps reach, if you want your study to be useful, to have some cutoff levels.
So we measured it, but due to the paucity of the time and the limited number of slides we had, so I had to cut it down.
It's very important.
And, yes, sir. It was 189.5 milligram per deciliters, which we got from our studies.
So it's important to get that message across to people. So perhaps if you present it again, it will be a nice idea to include.
Yes,
It won't take much
will
time.
Yes.
Okay. Thank you, Doctor.
Thanks.
So that with this, we in this session, anybody else remaining? So, okay. So before we jump to the next session, perhaps all the speakers, whoever are there, you can come up over here and we can take a picture. Take from here, no?
Please on my camera. Yes.